Hey, and welcome to the Davies Use Case webinar being presented by UCLA on improving depression screening in primary care with Health IT. This is the Davies Award-winning use case for the value of Health IT. My name is Arnold Simmons, and I'm the Manager of Quality and Patient Safety here at HIMSS, and it's my pleasure to moderate this presentation. Core to the HIMSS mission is promoting the use of health information and technology to improve the quality of healthcare delivery. HIMSS promotes and advocates the integration of clinical decision support and best practice guidance, access to clinical data to analyze progress, and information and technology enable patient safety tools for all healthcare organizations, clinicians, patients, and community members as vehicles for improving patient outcomes. HIMSS Nicholas E. Davies Award of Excellence is the pinnacle of the HIMSS Value Recognition Program. The Davies Award recognizes outstanding achievement of organizations from around the world who have utilized health information and technology to improve patient outcomes and value. The Davies Awards winning use cases have been peer-reviewed to validate sustainable, improved patient and business outcomes resulting from health information and technology-enabled care delivery. So it's my pleasure to welcome our speakers for today's webinar, Dr. Clara Lin and Kimberly Chen. Dr. Lin and Kimberly, I will turn the presentation over to you, and you can begin when you're ready. And thank you for joining us today.
Hi, everyone. My name is Clara Lin. I am a primary care med-peds physician and a physician informaticist here at UCLA. I am joined today by Kimberly Chen, who is a nurse and an informaticist, and who is currently the Population Health Portfolio Manager at UCLA. Today, we will be giving you a brief overview of our recent initiative in improving depression screening in primary care using Health IT, and to demonstrate to you our outcomes so far. Here is how you can get in touch with us for any follow-up questions. UCLA is a major academic health center in Southern California consisting of 4 major hospitals and hundreds of outpatient offices serving a wide area in the region. We are also still expanding our reach. Before we go into the technical details of our project, I wanted to share a brief story about why this project is so important to practicing physicians like me. A patient once visited an UCLA primary care office for a chief complaint totally unrelated to mental health concerns. The office he visited happens to be one that participated in this project, and so as protocol, the medical assistant screened him for depression and followed up with appropriate follow-up questionnaires. It was during these steps that it was discovered that the patient was actively suicidal and promptly admitted to the hospital. He is currently under active treatment and in the process of recovery. This is why this matters so much for us on a personal level, and now Kim will take over the presentation to talk about why this matters on a population health level.
Thank you, Dr. Lin, for providing us a glimpse of the problem of depression at the patient level. Unfortunately, the prevalence of depression is worsening, requiring us to examine the problem at the system and the population health level. According to the World Health Organization, depression is the leading cause of disability worldwide. In the United States, more than a quarter of adults and 20% of kids have diagnosable behavioral health disorder, and more patients are seeking their help in their primary care setting rather than going to a mental health specialist. At UCLA, addressing depression is such a major focus that it has been designated as one of 2 grand challenges. That is a call to arms for all of UCLA community, including faculties, researchers, students, staff, and of course clinicians, to come together and work toward a plan to cut burden of depression in half by 2050 and eliminate it altogether by the end of the century. It's a tall order, but we all want to do our part. Specifically at UCLA outpatient setting, we do measure several quality metrics related to depression for our accountable care organization goals. Namely the PREF-12, which measures the screening rate for depression among the well population, and MH1 addresses the remission for depression within 12 months of our initial diagnosis. For our presentation today, I'll first introduce at a high level the depression screening workflow at UCLA and provide additional details on the challenges we're facing. Then Dr. Lin will describe how we leverage IT tools to help solve some of these problems. Currently at UCLA, we have our operational standard for depression screening consists of 4 steps: screening, diagnostic evaluation, follow-up, and documentation and charging. For adults 18 years old and up without prior depression risk factors, our clinical staff will ask the first 2 questions of the PHQ tool. As you may know, PHQ stands for Patient Health Questionnaire, which is a 9-item questionnaire, a validated tool designed to help clinicians diagnose depression and monitor treatment responses. We've adapted a variation of this workflow in our busy ambulatory clinic setting by asking the first 2 questions of the PHQ-9. If the patient has answered negative to the first 2 questions, then this patient is screened annually. However, if the patient answers positive to one of the first 2 questions, feeling down or depressed, little interest in and pleasure in doing things, then we'll provide a PHQ-9 full screener on paper and allow the patient to complete it in privacy. Then our clinical staff will transcribe the responses into our electronic health record. Our provider will come in and evaluate the responses and provide management options. Finally, to wrap up, our providers will document in the notes and complete appropriate charges. To complete the cycle of the screening, if the patient has reported PHQ-9 score of less than 5, then they are screened again annually following this workflow. However, if the patient has an elevated PHQ-9 score of 5 or greater, or have a new diagnosis of major depression or dysthymia, then they will be screened every 3 months or so. Here are some sample screenshots from our electronic health record for each of these steps. In the screening step, our system dynamically displays the appropriate depression screening section if it's due for that patient, depending on the frequency and the content of the PHQ. Either PHQ-2 or PHQ-9 will display. In the evaluation phase, our system also automatically prompts our staff to print the PHQ-9 should it be necessary, and the staff will transcribe the responses from paper into electronic health record. In the follow-up step, our providers are reminded by alerts, best practice advisories in our electronic health record, if the patient has elevated risk of depression or if the patient's response indicates suicidal ideation. These best practice advisories also suggest follow-up actions, including referrals and documentation options. Finally, in the last step, our provider will look for depression screening infos within the chart, hunting and pecking through to find the documentation for today and incorporate it into their note. Remember, and also trying to remember what charges are appropriate to include in the visit. These operational standards were put into place, and we started to monitor these ACO quality metrics thereafter. Around September 2016, we found that our staff were only documenting 16% of all of our unique adult patients that are seen in the primary care clinic. This means that we have many missed opportunities to screen patients for depression as they come through our door. Furthermore, we found that only 38% of patients who have endorsed positive depression screening symptoms on the PHQ-2 do not have the PHQ-9 follow-up documented in their chart. This is really alarming, and it means that our patients who have told us that they are depressed potentially may have walked out of the office without further assessment. With those problems in mind, Dr. Lin led a team to improve the process by utilizing the PDCA methodology. This included 4 phases: plan, do, check, and act. In the plan phase, we performed site visits, collected survey responses to identify the existing workflow challenges, and met with stakeholders to review the current state. Here's a brief summary of the workflow challenges we've identified in the plan phase, categorized in the steps within the depression screening workflow. In the rest of the presentation, we'll go into more details for each of these challenges. Once we have the challenges and also revamped workflow in mind, we went into the do phase, which is to implement the revamped workflow, provide on-site training, and address the change management needs. Now, Dr. Lin will describe for us the implementations of various health IT tools that help alleviate some of these local problems.
All right. In an attempt to address the problems identified in the previous slide, we set out to optimize the existing workflow by improving the way that patients' responses are collected and utilized in a clinical setting. This slide right here provides a brief overview of all the tools that we've built and the steps we've taken. First, we moved the patient's response from paper to electronic, which allows the data to be automatically uploaded to our EHR in real time. As a result of that move, we are now able to build new tools such as new navigators, smart text, and charge capture activities using this new data. We also implemented an incentive-based program to encourage staff participation in tracking their performance using Clarity reporting. Once again, these are the 6 major obstacles that we've identified, and in the next few slides, I'll demonstrate how we've addressed each item. The first issue in the back office is that the staff frequently omits depression screening upon rooming, citing that they don't have time or that the patient does not have any mental health related complaints. As we've heard in our patient's story at the beginning, universal screening for all patients is important, even for patients who present with the most seemingly unrelated problems. To address this, we implemented a training program that included in-person visits to most primary care offices and meeting with the staff and doctors in order to reinforce our best practice workflow. We incorporated depression screening into the ambulatory nursing protocol, and we also built various training materials such as tip sheets, webinars, and a training website. The second and the most critical issue is the tedious workflow that involved patients answering the PHQ-9 on paper, which then requires practitioners to transcribe the response into our EHR at a later time. To address this, we implemented a web-based workflow to collect the patient's response, whereby the patient enters his or her response to a related questionnaire directly on the clinic desktop computer or iPad. Once the answers are submitted, results and scores are automatically integrated with flow sheets in our EHR. Not only does this remove the need to manually transcribe answers, but it also allows us to utilize this data much more effectively. All right, going back to our depression screening workflow diagram here, we have now optimized the second step by removing the paper process. Next, the third issue refers to the clunky workflow where the physician has to hunt and peck for the patient response. What we have done here is that we have built a separate behavioral health navigator that the primary care doctor can favorite into their workspace. Within this navigator, all of the patient's behavioral health questionnaire responses can be reviewed at a glance and can also be tracked over time. Our next tool addresses the fourth issue where there is often no interpretation to go with the patient's scores. A formal interpretation for the score is vital for providers and patient education as well as for billing compliance. Here, we've created an automatically generated score interpretation report that is uploaded into the patient's chart as soon as they submit their answers. This interpretation can then be printed for the patient and can also satisfy billing requirements. We also created a website for patient education resources. So now with the new navigator as well as the auto-generated interpretation report, we have optimized our third step and simplified the physician's review process. Additionally, we created tools to help with physician documentation and charging. Here on this slide, you can see that we've leveraged smart phrases to quickly pull in relevant scores into a progress note. Finally, we try to address any missed opportunities for any physician charge capture. Each of the behavioral health questionnaires, when completed and interpreted, can be billed for a CPT 96127 code. But this is often not done by physicians. We then created task-based order completion orders, or TBOC orders for short, that will automatically place charges for the physicians. We have similar TBOC orders currently in other office space procedures such as ear lavages and vision screening. Once the physician selects the correct order, And here we have separate orders depending on the numbers of questionnaires that are completed by the patient. The staff can then complete the task once the screening is done. As soon as the task is marked complete by the staff, a 96127 charge is dropped automatically on the physician's behalf. So now we have optimized our final step in the workflow and streamlined documentation and charge for the providers. Going back to the PDCA cycle, we continuously review performance report and collect feedback. Then based on this feedback, we can assess and implement for constant optimization. We utilize Tableau reports to track the performance and behavior at the level of each practice. This report is available to office managers in real time. As demonstrated below, you can see that our 15th Street Santa Monica office screened 31% of their primary care patients for depression with the PHQ-2. The total screening opportunity on the rightmost column displays the number of patients seen in that office during the time period that needed to be screened but did not yet receive screening. Out of the 3,463 opportunities in this office, only 1,075 were screened, yielding a percent screened of 31%. This number of percent screened is tracked, and a financial incentive is offered for the offices that achieve a specific performance threshold. We can drill down the report even further to assess the screening rate for each medical assistant. This report is also available for managers to be used during professional performance evaluation. All right, onward to clinical outcome for all of our efforts so far. First, I want to point out 3 specific time frames which will be marked with a corresponding arrow in the following graphics. First, we implemented the project to 2 high-volume primary care offices in August 2017. Then, 12 additional clinics came on board with this project in December 2017. And finally, we expect to roll out our project to the remaining UCLA offices at the end of 2018. Now, let's first look at our screening rate using the PHQ-2. Remember, this refers to the number of patients screened for depression using the 2-item questionnaire on the numerator over the total number of unique patients that are due for screening on the denominator. Back in September 2016, before we began our project, the screening rate in the participating offices was only 16%. You can see a small rise in the screening rate when the project was piloted in the 2 offices in August 2017, and then a further rise once the additional offices are onboarded. Our current screening rate has improved from the initial 16% to now 74% as of August 2018. Next, we'll look at the PHQ-9 completion rate. This refers to the number of patients who answered positively on the PHQ-2 screening and completed a PHQ-9 on the numerator over the total number of unique patients with a positive PHQ-2 in the denominator. Before we implemented the project in September 2016, our completion rate was at a 38%. This means that patients who endorsed depression symptoms for us, only 38% had a documented PHQ-9 in the system. Again, you see a small rise as of August 2017 when the project was implemented in the 2 pilot sites, and then a further rise as of December 2017 when 12 additional offices were enrolled. Our current PHQ-9 completion rate is at an amazing 91%. This demonstrates really quickly the total number of documented PHQ-9 in these total 14 offices by month. So as of September 2016, all 14 offices completed or documented only 73 PHQ-9s total. However, you can see that rise over time, and now we have completed close to 1,000 PHQ-9 questionnaires as of June 2018. This number of total PHQ-9s completed in each clinic translates directly into the 96127 CPT charges that we can bill and get reimbursed from insurance payers. As you can see on the bottom table in this slide, in calendar year 2016, the 14 participating offices billed for 2,231 charges of the 96127 code. This translated to about $15,000 of reimbursement. In the next calendar year, 2017, where we implemented the pilot project in the 2 offices in August, we saw an increase in the number of charges dropped from 2,200 to now 4,800, which translated to about a $39,000 reimbursement. In the calendar year 2018, which is annualized, we project to be able to bill to more than 9,000 of the 96127 charges, which then translates to an approximately $80,000 reimbursement. So our project, not only does it have a clinical benefit to patients, we're also seeing a financial incentive for the institution. Moving onward to the table above, we see that based on our increased screening rate, we're also increasing our number of new depression diagnoses over time, as well as our psychiatry and psychology referrals for our patients over time. So in 2016, we saw that of all the patients that are seen, all unique patients that are seen in these offices in the calendar year 2016, we diagnosed new depression in 1.7% of the patients. That number has now increased to 2018 calendar year at about 3.2%. Our referral rate to the Department of Psychiatry and Psychology also improved from 13.8% to now 17.8% between 2016 and 2018 calendar years. All right, with our project, we were able to achieve HIMSS's steps to value by improving universal depression screening rate and improving our diagnosis and management of depression and other comorbidities in primary care. We were also able to increase referrals to appropriate specialists, provide discrete data that are now readily searchable and trackable, and improved risk-adjusted coding and appropriate charge capture. The steps that we have coming up for optimization would be to build an express lane that would package all the depression-related content for the provider, and also to prompt providers with correct T-box charge suggestions in real time. We also would like to examine patient outcomes as related to improving depression screening rate in primary care, such as emergency department utilization rate, benzodiazepine use, and also depression remission improvement. Finally, we're also working on expanding our patient resources with internet-based cognitive behavioral therapy referrals, third-party meditation app integration, and also building more patient psychoeducation handouts. And that is the end of our presentation. Thank you very much.
Okay, and we would like to thank our speakers from UCLA for joining us today and sharing their Davies stories. We would like to remind listeners where to go find this story and other important Davies use case recordings and information on how to apply for Davies. That information can be found at the HIMSS Davies Award website at hims.org/Davies. That's hims.org/Davies. Again, thank you for joining us today.